Hello, everyone. Today we are going to be talking about feedback that works, practical strategies for faculty. So I want to start by acknowledging something most of us feel, but don't always say out loud. Feedback is one of the most important parts of our job and actually one of the most uncomfortable. We supervise learners every day, we observe them, we assess them, but translating those observations into feedback that actually changes behavior can be very challenging. Today, we are going to make this more practical. The goal is to live with language and structure so you can use tomorrow in your clinic. So my name is Ecler Jaqua. I'm the program director of family medicine residency and also the medical director of the Center of Aging of the San Antonio Regional Hospital in Upland, California.
And hi, my name is Soumya Sridhar. I'm one of the two associate program directors for the family medicine program in Rochester, New York. Our learning objectives for this webinar is one, to be able to describe evidence-based principles of effective feedback, learning how to apply structured feedback models in clinical teaching, and using language that promotes reflection and growth with our learners.
Okay, so why this matters? Feedback is central to clinical competency. It's how learners actually they calibrate. It's how they refine reasoning. And it's how they improve, of course, patient care. But it's also very central to professional identity formation. How we give feedback influences how learners they are going to see themselves. Are they going to see as capable, growing, or maybe just judged all the time? And ultimately, this is about patient safety. If we avoid the feedback because we are uncomfortable, the blind spots, those red flags can persist. So when faculty tell me, well, they feel unsure or they are pressed because of like time, like they don't have enough time to do the feedback, I validate that, but I also remind them that avoiding feedback has also their consequences. So structure is what allows us to give feedback efficiently and also safely.
Feedback has evolved over time. So earlier models emphasized episodic feedback, teacher-driven delivery, and correction of details. It was often one-way, retrospective, for example, end of rotation feedback, like here's what you need to fix approach. The limitations being low learner engagement and limited behavior change. Current evidence emphasizes longitudinal coaching, initiating a dialogue, making sense of the feedback that is being given, and essentially grounding it in relationships for growth over judgment. And again, grounding it in a longitudinal coaching process.
So psychological safety is foundational. Before we even talk about the models or the structures, we have to acknowledge something that is more kind of like the root, the foundation, which is a psychological safety. None of these frameworks, they matter if the learner doesn't feel safe. Learners are much more likely to actually use feedback when they feel respected, when they feel safe enough to struggle in front of you, and when they really believe you see them as capable of growth. So if they are worried about being judged, embarrassed, or labeled, their energy goes toward self-protection, so not learning. Fear and hierarchy shuts down curiosity. So, but when feedback feels like an investment, like, okay, so I understand, but when do we see this shift? Is when they see that we are on their side. Then they lean in, they reflect. So the environment we create over time matters just as much as the words we choose in that moment we give the feedback. So characteristics of effective feedback. Effective feedback is based on direct observation. and needs to be specific and behavior focused, not personality biased. It's limited to one or two key points. So we cannot just give feedback for everything. We need to choose max 2 points. It's timely or intentionally delayed for the right setting. The best feedback is if you give it like at the right time, like right away, or we can delay a little bit, but just if we have a purpose on that. And it links to clear next steps. Because if there's no action attached, it's just a comment, it's not feedback.
So, what are some of the common pitfalls? Being vague, just saying good job, for example, or addressing too many issues at once. Addressing multiple areas of growth can overwhelm the learner. Avoiding giving constructive feedback to preserve rapport. To Ecler's point that she made earlier, reluctance to give feedback can impair a learner's growth. Praise is not feedback. Praise highlights and celebrates what was done well, often in broad or general terms. Feedback zeroes in on specific behaviors or outcomes, offering information about what worked and what didn't and why. Praise can certainly boost motivation and reinforce positive feelings. However, feedback drives learning and improving by pointing out actionable steps.
So now let's talk about practical models for busy faculty. Structure reduces anxiety for both faculty and learners. So when we have a model in our back pocket, we are less likely to avoid the conversation. And learners experience that consistency instead of unpredictability. So let's look at some structured approaches. So let's talk about the modified feedback sandwich. Many of us were trained to use actually the feedback sandwich. Something good, then something bad, then something good again. Rather than just don't do it anymore, it was modified. First, normalize the feedback. Set the expectations early that feedback is routine and also part of growth, not a signal that something is wrong. Second, we should be direct. Name one specific behavior you observed, max two, but if we can just do one, that's better. Keep it concrete and neutral. And third, shift from critique to feed forward, and with a clear suggestion for what to try next time. The difference isn't the structure, it's the intention. We don't want to just cushioning the discomfort, right? We want to build clarity and predictability, which makes our learners feel safe. So why the classic sandwich actually doesn't work or often fails? Because it dilutes the core message. When we soften too much, the learner leaves like unsure of what action needs to be done or what they need to change. It also limits reflection. The model centers the teacher's voice rather than the learner's thinking. If we want behavior change, we need focus and dialogue, not a systematic praise.
Another model for structured feedback is the ask, tell, ask model. It works well in busy clinical settings. So the first ask is essentially eliciting the learner's self-assessment or their perspective. For example, by inviting the resident or learner to reflect on their own performance. This helps uncover their self-assessment and any uncertainties. Like, how do you feel the patient presentation went today? Or what aspects of this HPI's approach are you most and least confident about? The second step is tell. Based on their self-reflection, deliver concise observations and suggestions. Focus on specific behaviors and link them to any learning goals. Like, I noticed you summarized the HPI clearly, and this helped the inpatient team follow your reasoning well. The second ask is Ask the learner. So check understanding and plans. Make sure the learner has absorbed the key points and invite them to outline what they think are the next steps. This fosters ownership of their learning. Like, how will you incorporate, suggestions that, we've discussed into your next presentation? Um, and by cycling through these steps, you create a dialogue rather than a monologue. So the resident or the learner stays engaged. You tailor your guidance to their needs, and essentially you both leave with clear action items. The ask, tell, ask sample language. So for this model, some examples could be like, what part of that encounter felt most challenging? Or I noticed you move quickly past the abdominal exam in the observable behavior portion. Or what's one thing you'd like to try differently next time, essentially leaving it with the learner to make their next steps with you.
Okay, and then we have the ARCH model. ARCH is efficient and practical. Ask first the learner for self-assessment. This immediately shifts the dynamic from evaluation to self-reflection. Reinforce something they're doing well and be specific. Correct one issue, not three, maybe two, and then help them plan improvement. Okay, so what are we going to do next? So I like ARCH because it keeps things focused. One behavior, one adjustment, and that's what sticks.
The next model is the ADAPT model. So the first A is the ask. So ask the learner, start by asking them for their self-assessment of their performance. The D is the discuss observations. Share your specific observations and discuss that or compare that with the learner's self-assessment. A, so you ask the learner for ideas or you collaboratively agree on the key areas for improvement. And the P and T is planning together for targeted skills. So you work together to develop a concrete plan with actionable steps for improvement. The ADAPT model is a well-structured and collaborative way to give feedback and focusing essentially on making it more constructive and actionable.
The next model is the set-go model. The set-go works well when there is more complexity or when the learner has an agenda. You begin by seeking the learner's perspective, and then you explore what was observed. You think together about the meaning. And then you move into the goals and offers, but you do that together as a team. This model slows the pace a little bit, which can be powerful in emotional charged situations or professionalism concerns. So when learners help generate the goal, follow through improves.
Choosing the right model. You're a busy clinician, you're a busy teacher. Before giving feedback, ask yourself, how much time do I have? How safe does the learner feel? And is this an appropriate and safe space for you to give feedback to the learner? Checking in, is this about skills? Is this about a judgment? Or is this about the learner's professional behavior? And then, is this a one-time or a longitudinal interaction you're going to have with the learner? Factoring in all that can help you choose the right model that you can implement or apply at that moment with the trainee or learner.
Okay, so let's do a case and do a role play together. Okay, case scenario. So we're going to be moving now to reality. You have a very confident PGY2 and a ill-appearing patient with diabetes type 2 that is presented as simple constipation. When you probe a little further, the resident becomes defensive. This isn't rare. I'm sure it happens to all of us. It's premature closure layered with ego threat. The clinical issue matters, but so does the emotional dynamic. So both matters. So this is the moment where the feedback either is going to escalate the tension or is going to build insight. So let's pause and reflect. Before you say anything, ask yourself, what is actually happening here? Is this a knowledge gap, a reasoning shortcut, which can happen, a professionalism issue, or a threat response? And then ask yourself, what is my primary objective in this moment? Because we cannot fix clinical reasoning, defensive tone, and diagnostic bias all at once. So choose the one that most impacts patient safety now, because the precision makes the feedback very effective. Reflective role play. So now let's practice something that I have a hard time, which is restraint. Your task is not to correct everything. Your task is to guide thinking. How do you shift from "you're wrong" to "let's examine your reasoning"? Instead of debating the diagnosis, explore the process. For example, walk me through how you ruled out more serious diseases, more serious causes. That question is going to move the learner from the defense to analysis. And this is where coaching is going to replace correction. Simple faculty language. Notice the difference between confrontation and curiosity. So confrontation is going to sound something like, yeah, that's not constipation. Coaching is going to sound like, hey, help me understand how you prioritize constipation over other possibilities. So one is going to shut down the conversation. It's not constipation. You're wrong. The other one is going to open. So a specific, calm, process-focused language keeps the learner thinking instead of just protecting from us. Closing the feedback loop. So feedback is incomplete without follow-up. The next time a similar case arises, briefly reconnect the dots. I noticed you brought in your differential earlier. What shifted for you? Now you are reinforcing the growth, not rehashing the error. That follow-up transforms the feedback from a moment into development, and that's what makes it stick.
We hope that this webinar has been helpful. Some key take-home messages: treat feedback as an ongoing conversation rather than a one-off interaction when you can. A predictable framework helps people feel secure enough to hear and act on feedback. And too much information can overwhelm and stall improvement in the learner. So one clear, actionable message matters the most. These are some of our references, and thank you very much